computer. Okay, welcome everyone. Good evening. Welcome to this special discussion about the Netflix film short series, really, Painkiller, which has just come out, and it's 6 episodes regarding the opioid epidemic in the USA. Today, I have with me Dr. Magdi Aglan, who is a senior consultant in pain management at East Lancashire Teaching Hospitals, medical director of Pain Consultants Limited, and a good friend of mine. Welcome to the show, Magdi.
Welcome to you, my friend, and thanks a lot for inviting me to talk about morphine, opioid, or whatever. They're all a regular part of our routine work.
Excellent.
I'm really interested to talk about them.
Oh, great. Well, when I came across this short series, and a lot of people have been recommending it to me, Magdi, to watch this, I have to say, both in the workplace, out of the workplace, doctors, non-doctors, everyone's been recommending this. And I thought I had to get you on board to get your thoughts. And it's always good to get a safe pair of hands, someone who knows the subject well, to guide us through the discussion. So over the course of about an hour or so, we hope to discuss many different points regarding themes that I've picked out, and hopefully the audience who watch this video will also enjoy the discussion as well. So let's start with the basics, really. Magdi, what did you make of the series? Do you want to give me a general thoughts first?
I have to say, obviously, as they said, they made it a bit really drama so they can get the audience. But the topic was very, very interesting. The painkiller. So who hasn't got pain and who doesn't want the pain to go away? So it's very interesting title, and the story really was dramatized, but there was a lot of facts really terrifying people about the use of opioid, which for us as a doctor, especially pain doctors, is a routine work, and we don't feel we're doing anything dangerous. It just, once you know what to do, it becomes safe. Either you know or you do not know, as simple as it is. So opioid from that point of angle exactly has been, I think, Bordeaux, which is the company which did the OxyContin, exactly did a lot of mistakes, as seems. Actually, they've been quote unquote as well doing that. So the biggest one, exactly that, it's a marketing, the very strong obsessive marketing. Like, for example, people in pain, and we use different drugs to help them called analgesics. Opioid is for strong morphine-like drug, is for strong, moderate to severe pain. So they already, I think, produced the slow release morphine in the 80s, and then they started the OxyContin, which is oxycodone, again, but they wanted to push it and to sell more of it. And the clever things about them from their point of view, exactly like all the strong drugs, especially morphine, the market is about like 15% for cancer pain, and the majority of it for non-cancer pain. So that's what they exactly, to market it more, they went for non-cancer pain, back pain, post-traumatic, post-surgery, post-whatever, for non-cancer. And that's what spend a lot of money, and that, again, trying to change prescribing practices and give sometimes false information, especially about the risk of abuse of these drugs. So I think they were not really honest or in their marketing strategy, and definitely resulted in a lot with the increased prescription. There was, again, increased more of abuse and death reported in the same areas where they reported more use of that OxyContin. So it was serious overuse or abuse of that drug, which obviously, if being used properly, would have not caused that harm.
That's really good to set the scene. Thank you, Magdi. How do we actually manage, though? One of the themes is opioid addiction, and this is a problem across the world. Magdi, do you have any thoughts on how we actually can manage this in the healthcare system?
Yes, addiction is like any other problem, is a medical condition. So it need to be diagnosed, then properly treated, as simple as it is. So but it's even better to prevent it. And that's part of a lot of the legislation and the policies and protocols and the guidelines of, again, the use of and prescription of these strong opioids to avoid that from happening. But if it happened, it's like any other condition. Once you diagnose it, there is definitely facility to treat these people successively. It sometimes be difficult in certain patients because it's not only physical but also psychological factors as well. But the condition itself is dangerous because it does not destroy the patient's life, but it destroys his family and consequently the social, all contacts of his life because of that addiction, as their behavior become compulsive and drug-seeking behavior, and then they started to withdraw interest in themselves, and then they would do loads of wrong things just to get the drug in an unlawful way. So it's definitely, for me, it's better to prevent it. But like as I said, any condition, you diagnose and then treat. We see patients with addiction in our clinic, not directly for their addiction, but they come as part of having other medical condition. And when we suspect that they have been taking the drug, strong opioid, morphine-like drug, OxyContin or any other drug for a long time, and they still report pain, the first step is just to get the patient to agree that they're taking a drug which does not help their pain. That's the first part of successful treatment. If the patient agree on that point, nearly all the patients succeed. But if we have a difficulty in getting that idea first and commitment from the patient first to say, yes, I've got a problem, most of the time we do not succeed in helping them. But once they admit that it's really, and that's the idea, they said, I can't cope without them. For example, like recently, I think a couple of weeks, I've seen a patient like this in my clinic, and he was saying the same. He was in severe pain, and he's been taking drugs similar to morphine for a long time, at least 6-7 years. And he's still in severe pain. So how we know that? Pain is subjective. So whatever the patient say, we believe him. So the patient says he's in severe, that's it. So we asked him first to measure their pain. And he said his pain is 8, 9, or 10, which is very severe on a scale from 0 to 10. So it's very severe. So if the patient say his pain is still the same, 8, 9, or 10, after taking the opioid or the morphine-like drug, that means the drug is not working. So I said, if you stop the drug, you'll be exactly the same pain, but hopefully without the side effects, which start to destroy your life. So this is the bottom line. With addiction, people will feel the urge to keep using the drug despite harm. So you know it's harmful to them, but they still, the drug itself have that physical effect and psychological effect on them to keep using it. But when the patient really realizes that they've been taking it for a long time and they're still the same pain, so that's the first step, recognition that's not helping. So practically in our clinic, we use what we call gradual withdrawal, gradual program, which was reduce the dose of the drug by a certain percentage, depending on how long he's been taking it, until we get it totally out of his system. But if that fails, there is another service, very good local service. We're lucky in Lancashire to have it. It's called Inspire, and they really got the physical knowledge and psychological knowledge to help this patient again to go through any different addiction. So that service is available and it's successful actually in our hands, and our patient really make use of that as well if they come across. But addiction is look like a stigma, but it's nothing new. Since the use of morphine and people know that's being abused, people can get addicted. What's new is that really is being realized properly as a medical condition. And I think from the 70s has been really started to have program to treat people successfully from this condition if it develops.
Okay. And in terms of, obviously, for those who might not have as much knowledge about pain relief and opioids. Can you go through the WHO, the WHO guidelines a bit for the audience? Would that be okay with you, Magdi?
Yeah, I think it's actually a very good step, because maybe in England we've got even with our current apparent problem with this healthcare system, but we really good system which really been treating patients with different types of pain. But in a lot of other countries in the world, there was even people afraid of prescribing the drug at all, even in a proper a post-surgical condition, on a fracture, severe fracture condition, or cancer. Sometimes cancer patients, some parts of the world do not have availability for even morphine, which is really serious scenario. So the WHO, the idea, just a simple step ladder, basically, of 3 steps, depending on the severity of the pain. Mild pain, so you use something like paracetamol or brufen, something usually over the counter. Then moderate, you get slightly stronger drug like paracetamol and add codeine to it. And then if it is severe, you can start from strong medication, and the gold standard is morphine. So if it's mild, you start with mild drug. If the pain moderate, you start with set away with moderate drug. And if it's severe, you start again strongly with morphine or oxycontin, which that's what the the painkiller series was about. You start again from strong drugs straight away, and that's what we use. Like I see a lot of patients with fractured spine from osteoporosis or cancer, and I do like treat that with cementing, injecting cement into it. It's called vertebroplasty. But we give them first few weeks trial of strong analgesia. So we start straight away from morphine or oxycontin, because they really got severe pain and we need to get that pain under control so we can help their function. And if the patient get better within about 2-3 weeks, that's fine. If not, we can now plan after that for cementing the fractured spine by vertebroplasty. So this is the WHO, which really was like simple, but it did help a lot of countries to develop legislation to have availability of strong drugs when you got at least cancer pain, which some patients do not have even strong analgesia to be treated with. So it's very useful, guidance. And there's a lot of modification happened to aid different drugs, got to different things. But the idea, when you get pain, you have to treat it. You cannot just leave the patient in pain. And even strong opioid, if you use them properly, you will not get, the side effects. And if they get side effects, you try alternative drugs. But it's not uncommon, in, like when we get the patient for us, the tertiary pain center, we use not only one drug. It's common to use a combination of drugs. Like we usually think about the axis, the way the pain is transmitted from the origin of the pain to the brain. We call that the pain pathway. And we use different drugs working at different part of the axis of the pain transmission to try to get the best analgesia and safe analgesia for the patient. So that's what we professionally do. Mix different drugs, work at different mechanisms to get the patient better pain control and more tolerable drugs, and less need, improve their function, better sleep, and less need to develop any side effects.
That's great. I want to bring in Yasser Ilahi now, my friend who's in recruitment. Hi, Yasser. You okay?
Yeah, not too bad, thank you.
Hi, Yasser. Good to see you, and thanks for joining us this evening. Obviously, Magdi set the scene really well there in terms of pain control from his background as a pain consultant. But I'd like to go to you, Yasser. First of all, your thoughts on the show and some general feedback.
Well, I thought the show was amazing. So the word that strikes out from the start to the finish, to from the first episode to the last scene in the last episode is for me the word manipulation. It's well, there's another word actually, ethics as well. So from the get-go, from the very start of the first program, they're setting the scene. They're trying to talk about what's happened over the past 2 decades, and looking back further beyond the 2 decades as well. So think I said the word manipulation. I think that strikes out from the very start. So, your medical organization, which is its business is ran on making money based on manipulation. The medical sales rep, who their job is to manipulate, the doctors, and manipulate essentially what goes on in the industry. And then boiling down to the doctor itself, the people that are prescribing these drugs, they are essentially manipulating how the next 10, 15 years are going to look like. The end user or the patient, if you want to use the correct term, the patient in this matter, is really helpless. They start the journey off in need, and trust, and they have a lot of trust in the process, in the system, but essentially they've been manipulated, and it's a horrible story, which, like I said, it's nothing new. This has happened for decades, for centuries, and I guess that's where the word ethics comes into play. Who in this storyline and real life, really, who is acting ethically? You'd expect all three particular people in this storyline to act ethically, apart from the patient. You'd expect them to act ethically, but they're kind of out of the picture. When it comes to addiction, ethics goes out the window. And the show, the one of the main storylines, where the character is a mechanic by trade. He has a workplace accident. He's prescribed the painkillers, and he has trouble. He really struggles to get off them. He tries, but obviously it's not to be. Once you're in deep with these painkillers, where else can he go apart from wanting more and more? So the ethics for that particular character, or that the patient, should I say, really does go out the window. So you'd have to ask the question: is the medical organization acting ethically? They could argue, yes, we are. We're providing a service for a need, and we're doing it in the best way possible, we believe. And that's the kind of message that they put out there from. And again, in this storyline, in this program, that's the message they put out there. We're providing service. We're doing the best for the community, for the people. It's really not our fault if they get addicted to it. And then you ask the question to the medical sales reps: are they acting ethically? So, I mean, in my view, definitely not. There's no ethics involved in the medical sales reps. They're seeing pounds and dollar signs. They're seeing, again, for themselves, a journey from coming in fresh. I think one of the main characters was still studying, or just leaving the studies. She's no money. She sees the pound signs, and again, ethics goes out the window. It doesn't matter what's happening with the end user. It doesn't matter what's happening with that patient. The fact that the doctors are working in for her needs, she's making a lot of money for it. And then the doctor, in this program, obviously they've looked at several doctors. Are these doctors acting ethically? They should be. Their job is to be ethical. From a moment a patient walks in through the door to a resolution to whatever problem they have. The doctor should be acting ethically. I think what the program brought out is, the ethics for the doctors were going out the window. It was a very, I suppose in financial terms, a very sexy industry, for the amount of money that everyone was going to be making. Doctors, may well not have got a financial, gain in this, but they were getting other things. They were getting meals, they were getting lunches, they were getting dinners. Some of them ended up having relationships, with the reps. So again, the doctors, and apart from the select few who really looked into the painkillers and really looked into what it is that they were prescribing. The ones that actually stood their ground, the majority were not acting ethically and were just being manipulated.
Magdi, I want you to come in there and talk about the ethics and manipulation.
Yeah,
and some
of
of the points
course.
that Yasser said.
They already admitted from the beginning that they've done a lot of things just to make it a drama. So definitely, but the question is still valid. Number one, I think the company Voodoo definitely, who did produce MS content, which is slow release morphine in the 80s, did exactly the same, but even much more, spent millions of money, like 10 times more than any other drug for the same things to market that drug. So number one, that's something even picked up by the FDA from the beginning. And then the way they marketing again, it was not right. Again, I think not only giving the doctors incentive in many ways, as you kindly said. Not all the doctors, of course, followed them. It's just the drama, necessitated that action from them. But they also produce some like free drug. They give like free drug for the patient first, and after 3 months they stop that program. So until the patient get hooked, and then now they stuck. So they did all the tricks to change the prescription and the prescribing attitude for doctors and affect the patient. And then also, although the drug itself is a slow release, that's mean it's less likely to cause addiction. But the people quickly, for abuse, discover that if they get the material out of the capsule and they crush it, they get the quick action of it, they get the high of it. Again, they can solve it, they inhale it, they inject it, so it become really abuse matter. And also they were not honest. I think, as far as I know, if that's what they said, and then I think the court got them, they talked about the incidence of addiction is less than 1%, which serious, actually can go up to 15%, from 3 to up to 15%. So to say that that drug is safer than the other is seriously wrong. So even they were not honest in their marketing. I think they had the court against them specifically for that misinformation. So it's, as you rightly said, anything, if you abuse it, including painkiller or not, it will kill you. And that's epidemic there. And obviously it's been properly abused by everyone in the industry. It make you suspicious that I don't know, that can happen, anywhere. Would that happen in England? I've been a consultant for 25 years, and I actually haven't seen that happening in my environment to that degree. And especially with opioid, especially restricted drugs, there is a lot of guidance in prescribing them from the doctors and the pharmacy to dispense them, even in the if you are a patient in the hospital, if you get morphine, it has to be checked by 2 staff members first. So there's a lot of rules and restriction to prevent, again, the abuse or the wrong use of these drugs, to be safer for the patient. So I think the system is full of these guidance. And I was involved in writing the guidelines for the Northwest use of opioid for non-cancer patient as well, guiding doctors again how to use them so we can get what they intended for. They are strong analgesics, and if you take them, definitely if you are while you're in pain, you will never get high, you'll get pain relief. So but if you take them while you are not in pain, now you may feel the high, and then you can get hooked to their addictive effect. But I've never seen a patient who's in pain and we give them morphine or OxyContin, which is double the strength of morphine, and they get addicted to it. If you are in pain, you never get addicted to pain, to these drugs, because you use them to relieve the pain, and that's what you get. You feel less pain to get you back to function. But if it's been properly abused, gradually the body get used to them. So they call it first like tolerance. So you have to increase the dose to get the same effect. And if you keep doing that until all the receptors in the body get saturated, then you get the psychological effect and the behavioral effect, which that we know about the addiction, and it's like a really dangerous form and the effect on it. So it is really like I said, is like any other drug, any material. If you use it, any drug, sometimes say the patient, it's a poison. We give it for an effect, and there is a very narrow margin. Below that dose, it will not have an effect, and more than those will give you side effects. And within that recommended dosage, that's we are allowed to use, so we can help you without harming you. There's no point of helping you and give you a bigger problem down the line. So that doesn't happen. So any patient who in severe pain and his GP or a consultant give him strong opioid, there is a good reason for that, and he's in a good system to follow that up. And I've never seen the same drama as it's really the series did show that. But in the States, it's a real problem because there is a lot of mortality reported. So it's not only addiction, there is death. People died from the drug, which was really a horrible outcome. You know, instead of giving the drug to help people with severe pain, with or without surgery, the people use it like any simple drug, and their kids end up dead. That's really horrible outcome. So that's what was really dangerous about the drug. But from our side as a doctor, again, like anything, you have to use it properly and just make the patient more aware of the risk, and lots of time to educate the patient and answer all the questions. And as I mentioned to you, Fahim, at the beginning, it's just when we come across a patient who got addicted to certain opioid drug, morphine-like drug, the first step for success is to convince them, and the patient is aware that he's taking the drug which is not helping his pain. Full stop. So why are you taking them? So that's a question. Once we pass that stage, there is, again, it is not that really difficult to get them through a gradual withdrawal program, get the drug out of his system gradually. Or if we don't have the facility, we've got a very successful service. We're lucky in Lancashire to have this called Inspire service, who are doing a fantastic job for patient with opioid abuse.
Okay, thank you. Yasser, I want to come back to you now. Obviously, this is really a program that showed a keen interest in yourself and developed it. What are your thoughts on opioid addiction? Any common misconceptions or myths that you see in the public sphere, or even regarding discussion of legalization of certain drugs and so on? What's your thoughts on this big domain?
It's a big area for him. So I think one of the things that really interests me is in terms of the addiction itself. You think when you say the word addiction, you are looking at your illegal substances, which obviously you're not getting through the proper channels. In this particular scenario, what you're doing is you're falling into, again, the addiction world, which is through a legal channel, through through a recognized route. So something a drug that's been researched, passed for sale and distribution, and somebody has prescribed and allowed you to take this on a regular basis, which you then go and abuse the instructions and obviously addiction forms. I think one of the things which I wanted to talk on, or to maybe develop on, and certainly is look at some of the common misconceptions or myths, regarding regarding the opioid addiction. I'd be keen to take your views on that, to be honest.
Yeah, addiction, as I mentioned to Fahim just before you join us, it's like any medical condition for us, is like a disease. So we deal with it like you got a medical problem, we diagnose and we treat, as simple as it is. But from the patient point of view, obviously, there's not only the illegal way, but There's a lot of shame as well. People will not really even let their parents know or their family members know. There's a shame attached to it, which can affect the behavior, and until the patient is too late in the condition itself. So usually transparency in that scenario is very, very useful. But for us, it's a physical and psychological. That's a real problem. It's not only physical problem. You have also to look for and diagnose and respect this psychological effect. And so it's a mixture of both. And we treat both. So there's treatment for both of them, and the treatment is available and treatment is successful, as far as I know, from my specialty, to a high degree of success, of course, with the patient cooperation. But some patient, as it may happen in the series, may relapse. Again, if they don't have a proper social support, they may relapse. But technically, addiction for us is fine. We've been prescribing opioid and morphine all over our career for years and years. And for us, we give it for a reason, to help the pain, and we monitor that for a safe outcome. And when there is a need, we stop it. There's nothing new. It's not for the rest of life, like drugs for blood pressure or drug for diabetes or something like that. No, when there is no need for it, you stop. And when we use opioid, there's a lots of mechanism and tricks the doctor would do to prevent the patient from getting, again, tolerance. Once the patient started not to respond to a drug and recommended bigger dose, and that's we call tolerance, we should not just keep at it. We look for alternative medication, physical, psychological, injections, different chemicals. There is lots of other drugs which can work in a different receptor, different part of the body, to end up reducing the patient's pain, so we can reduce his reliance on these opioid drugs. There's too many ways we can do safely to get the patient away from that addiction. But that's for us, it's routine work. There's nothing new. We see that, we do that. And I think we really, comfortable with doing it. But from the patient's point of view, it's really traumatic.
So at what point would you draw a line? Where do you draw the line? If you see the addiction or you sense an addiction, at what point do you say, I can no longer prescribe this? Even though the patient is asking for more, or is asking for a higher dosage or double the strength, or whatever the patient is asking for, because they've seen the effects of this drug and they're demanding more. At what point do you draw the line because your ethics kick in?
Usually you decide the cause of the pain. And say, for example, if the patient got certain cause of the pain, so you need a certain dose, like an infection, you give a specific dose of antibiotic. So there is a range, safe range. So you start by the slow, and gradually increase the dose until the maximum safe. So if you arrive to that maximum safe and the patient still not getting help, say, sorry, I have to stop it. Why is not working? It's like a poison. Why I'll give you a drug which will give you harm and you're still in pain? We have to look for alternative ways. And that's the patient accept. So that's the point when we stop. When the patient started to develop that tolerance, that's mean he need more dosage to get the same effect. So his body got used to the drug. That's the point where we say, well, once we get to the maximum recommendation dosage of that drug, say it's unsafe. Say, sorry, we are not here to harm you. No doctor is trained for that. We cannot go that way. Not because you ask. Your problem is you are in pain, and we'll find other ways. And there is other, as I said, too many other drugs and too many other actions, surgical or non-surgical, physiotherapy, psychology, you name it. There is different interventions available to us in the pain clinic, which can help the patient reduce the pain, apart from just simple increase the dose, keep going up. So none of the doctors, as far as I know, or the consultant will do that. Will stop. If it's not helping you and it's gone to the maximum safe limit, sorry, I can't give you that because I'm harming you. What's the point of harming you? You're not here. We are not here to harm you, my friend. Tell the patient, we're here to help you. And so far, all the patients accept that. Because they come to you, they need help. Not just a recreational drug, that's different. Prescription, but for us, they come for a pain. So if you get pain, I will look a different way, look in different direction, and proper multidisciplinary ways, looking for different aspects of the patient's pain, biopsychosocial, the physiology, psychologically, and the social effect, and find exactly proper plan to help him coping with his pain without relying on one drug, especially if it started not to give the desired effect. Not just like a bucket, keep pouring into it. That all the doctors know that, and all doctors will not do that. But that obviously was not happening in that series. It seems like, the patients, you're right, but I need that. So why you need it? But you're harming yourself. It's becoming unsafe now. So part of the, I think, definition of the addiction, that the force of the patient have to use a drug despite harm. He knows that it harms him, but he still use it. So that's not a medical use. But from our side, yeah, we definitely can help you. We look for every way, every direction we can help you. And we are ready to do that. Not only one, we do 5, 6, 7 or more, whatever it needs to be done to help you pain. We make a plan, see what are the factors. But once, as you said, the point is, once the drug started to goes up with no effect, and once we go to the safe dose, every drug has a safe limit. They're all poisons. Even paracetamol, which is the safest drug available in the market, I think it killed more people in England than anything. People take it and kill themselves. They abuse the drug. So any drug is a poison. You have to use it in a special dosage, the recommended safe dosage. So once it goes to the higher dose, which is not achieving effect, we don't go up. Say, sorry, we'll harm you after that. We better find something safer. And all the patients accept that, because they come ask for help and we provide help. It's not just to give you what you want. That's what we can do safely to you.
Yes,
I hope that answered the question.
Yes, absolutely, 100%. Yeah. If you have a patient that comes through the doors, they're asking for example, in this situation, if they're asking for OxyContin, you put your foot down, you draw the line, you then make a decision. You're no longer going to prescribe OxyContin because you see the addiction coming in. You see the symptoms, or you see the signs of addiction, which you're looking for. Would your thought process not from there look at or try to understand that this person will not get OxyContin from yourself, but will go and try and seek it out from other avenues? And with that being going directly onto the streets, coming from from illegal channels, not non-recognized routes, people who are literally selling them on the street, which is exactly
what was sometimes we get, and patients say, I've been in pain for whatever condition, and I got this drug from a friend or a neighbor.
Yeah.
And I took one dose, and wow, all my pain disappeared. So that's usually the beginning of the story of the patient requesting. Most of the doctor would have like a defensive. If you insist on that drug, you must be going to abuse it. But we are really reasonable. We look exactly what's his condition, and if his condition really causes severe pain, and I'm aware of it, then there's nothing wrong with giving him the safe dose. The limit is when the dose becomes more than the recommended dose. That's it. That's what doctors follow. Because they are poisons, if you use any drug more than it should be, you're going to harm yourself in one way or another. So if we cross that limit, which we do not cross that limit, then we say, that's the point when I said, sorry, my friend, we tried that way and it didn't help your pain. It was working before, I agree, but now it's not working. That's what you told me. So the answer is not to give you more. The answer is to change it. If I keep giving you more, I'll make you addicted and you're still in pain. So he will realize that we do that to help him, not just to do that. But if the patient, for whatever reason, coming to your scenario, he decided to do that, I've got little things to prevent him from doing that. But our job, again, has to be safe. That's ethics, which you said at the beginning of your career. And I think, I've been consulted for long, and I've never seen anyone abuse this from like GPs or consultant, different specialty, do the opposite. They all think, sorry, what's safe for you? They may not come across clearly that we done that decision for your safety, but that's a target. There's nothing against you at all. We're here basically to help you in any way within my specialty, to help you. But if anything goes wrong, or the risk is more than the benefit, everything is potential benefit and the risk. We don't go there. Like surgeons have the same as well. They may decide in a second, look at the scan or whatever, and say, sorry, I can't give you surgery. That's it. The patient go out crying. But when you look at it, you find exactly that there is a serious side effects of the surgery, which if he had gone through, considering his medical condition, would have really got a major potential side effects. So it will come clearly that is done for the sake of the patients. It's done for his safety. And that's what all the doctors, as far as I know, does clearly. Just follow their experience, to use whatever they got in their hands as armamentation to help the patient, using opioid or not. It's the same. Anything can cause help, we go for it. Anything becomes risky or more side effects, we don't go there. And we explain that to the patient, because he may go and he say, we complain about you, you didn't give me the drug which is helping my pain. Then I would say, you told me your pain is 10 out of 10 with that morphine. So why you want me to give you morphine again? If it's not been, if I request to give you the dose from 100, 120, 140, and you're still in pain, I can't give you more than this. Then it become unsafe in a daily basis to keep doing like this. Then I said, sorry, I can't harm you, my friend, even if you wish that. I know you're desperate, but we better think of another way. And we direct attention, their thinking for another plan, and usually find another plan to get them away from that. But if he insists on it, and if he's already hooked on them, and if he's already become addicted to them, and he just need the prescription from me, we never do that. We don't feel pressure that we have to harm the patient, even if they wish so. We document that clearly, why we said that, what's happened that, so to protect him as well, the patient, more than anything else. And I think that's, from my experience, 25-year consultants, all the doctors in all the specialty does exactly the same. And it's not only opioid, is anything again could be the same harm. Anything abused will cause even more harm. But it's a mutual interest that pain is very common, and there's too many causes for pain. And opioids is one of the gold standard. Morphine is the gold standard for treating pain if it's severe. So, and we've been using it for years, and addiction is known for years as well. It's nothing new. But there is lots of regulation on the doctors, on the pharmacy, and the dispensing people, to be sure that they're developing and giving the patient the safe care. That's a trick. And I think we are very good at it in England at the moment, from that point of view, as far as I know.
Yasser, I wanted to ask you about pain relief at this stage. Obviously, the show mentioned chemical substances to try and manage pain relief, but there are so many ways to manage pain relief, more non-invasive methods in terms of, for example, acupuncture, maybe cupping, other things, transcutaneous electrical nervous system, TENS machines. Yeah, so watching this series, are you more in favor of those things, or do you have a different viewpoint on these things?
I'm in favor of any alternative method. The problem that you've got is at the beginning of, I think it was episode 1, the Dr. Sackler, he was talking about, mankind is built to, seek relief when he has pain. And it's a vicious circle, and talk about pain relief, and that unfortunately is how life works. So you can provide as many alternative methods, alternative reliefs as you can possibly think of, and I'd say they will be well prescribed. There will be a large proportion of society who will opt to try and use, you know, these alternative methods. The problem with addiction is that, I mean, it's the wrong thing to say about addiction, but it's that terminology where, you know, people say it's rather Moorish. You know, you really can't not have it. You know, the thing with addiction is you take OxyContin off the shelf. There'll be 3 or 4 other medicines behind it that may not do the same thing, but they will do. You know, in the right doses, in the right amounts, they will get to the same place as OxyContin has done. I'm not a chemist in any way, shape, or form, and I hated chemistry at school. But each of these drugs has a very simple, or simple for chemists anyway, simple chemical formula. And you know what you've seen is people engineer these chemicals in the way they want to manipulate it, and there's the word manipulation again, to get what they want from it. So you can take OxyContin off the shelf, but you, like I said, you will have either through legal means or illegal means something that will replace it, and that's where you will never do away with addiction. And it's one of the worst things mankind has had to face. You know, probably from back, you know, from the dawn of time, where, you know, you must not have, you know, something which is bad for you, but you want it because you know it's bad for you. But the feeling you get, you know, the euphoria you get from having it is, you know, can't be matched. You know, from simply doing, you know, or participating in, for example, some holistic remedies or something like that. It's just not going to work. You know, our brains are set up to match that level of high or that level of euphoria. Like I said, you know, you've experienced once and you want that again, and you want that again and again and again. You know, some people are fortunate enough to come off the drug. Some people are fortunate enough to focus their energies, you know, into better things, into things that will change their lives. But not everybody's built like that.
Okay, I'm conscious we're short of time, and we are coming to the end of the program. The time's flown by, actually. It was always going to fly by.
Yeah.
So Magdi, if I can come to you first, lessons learned from the program for you as a practitioner, for society as a whole, and then Yasser, you've got a few minutes extra, and then it coming to you.
I think definitely it was a good point because it really highlighted a very serious problem, which is addiction, from the patient's point of view. And for me, what was even worse is the death, not just addiction, which is treatable, but if he died, that's it. That's even worse. So that's it did that trick here, and it terrified to some point people of using the opioid if there's no need for it. And for all my years of experience, 25 years as a consultant, I've never seen a patient get addicted if he take strong opioid for pain. You don't get the high. You get pain relief. But if you use it the other way, just for the high, that's a different use. And it's not our job. We don't do for that. So I really did like it because it's focused on something important, something common, and something I hopefully change the people practice, both doctors, legislator, people do policies or whatever, and also the industry as well who manufacture drug and the marketing. So from that one, I did like it because it just covered too many useful points to too many people.
Great. And Yasser, what did you think are the lessons that we can all learn from the series that we can put into the workplace or just in society?
Well, I think it's the you know, the regulation side of things. You know, so you know, it shows you the hoops that they had to jump through to get this drug onto the market. You know, the research and development that they had to go through. But it's, again, you know, it's the doing things in a backhand way. It's, you know, taking shortcuts. It's doing things not in a correct way, which got this drug onto the market, which shows you there are still, you know, there's still gaps in the regulation, you know, which is being set up to prevent this kind of thing from happening. You know, what comes out of the market, what comes out in the street for people to take for, you know, for pain relief, you know, is tried, tested, safe, and the level of abuse, is always going to be there, but it's manageable, or it can be reduced through certain avenues. So regulation is certainly one, better regulation, but it's the alternatives as well, like you said, Fahim. So yes, there are currently alternative remedies out there that people can look into and try and relieve their pain in other ways. But it's looking at the big medical companies. Are they truly looking at the alternatives themselves? Are they looking at the type of drugs that they're bringing onto the market in the best way possible, or are they just seeing pound signs? Yes, it's a massive industry. We're talking billions as opposed to millions. So it's not in their best interests, for the big pharma companies to bring out something which is tame, so to speak. They want something which is, something has great impact, and people talk about and people want. That's a dream for the pharma companies. So, and that's exactly what they're doing. But it's that change to take them away from thinking like that and purely thinking about, is this going to relieve the pain without causing more pain?
Great. I think that's a lovely way to finish. I want to thank you, Yasser, for directing me to the series and drawing my attention to it. And I really enjoyed watching it, and it's quite thought-provoking. There's sadness in there, there's some humor, there's many different things. It's a real drama. And obviously, even though there's fictitious things within the series, there's still obviously a lot of truth behind what's shown. And just for those who've not seen it, I don't want to spoil the ending or anything, so they can watch it themselves and make their own opinion. Any final words from yourself, Magdi, before we sign off?
I think it's, again, one of the good things about it is just a lot of people now become afraid of getting addicted, which is important, and they realize the importance from us. It's like any other condition you diagnose, you could be easily treated. It's not the end of life. But the other point, which the death, that's what I didn't like seriously about it, from it, as you cannot do anything about it now, of the addiction itself and the fear. Now I think the patient can ask, and you've got reference to it, and that drama from that point was very, very useful, to be honest, putting that important question: does it worth just for that high to destroy my life and the life of my family as well? So for me, that was very, very important point, which I did like it, but it was, as you said, it made it a very good drama, and I really enjoyed for following it up.
Thank you so much. Thank you, Yasser. Thank you, Magdi, for both your time this evening. Thank you so much. I've been your host, Fahim Shakur. Thank you.